Hello and welcome to our webinar, How to be a Rockstar for Tourette and Tic Patients. My name is Brenda Peart, and I'm the Manager of Programs at the Tourette Association of America, and I'll be your moderator. This webinar is being provided as part of the Tourette Health and Education Program, a program of the Tourette Association of America in partnership with the CDC. During the webinar, we will be very happy to hear from you and include your voice in the conversation. You may ask questions or share your comments using the comment section at the bottom of the screen. All questions will be addressed during the Q&A session at the end of the presentation. I would like to mention that funding for this webinar was made possible by a cooperative agreement with the U.S. Centers for Disease Control and Prevention. The views expressed by speakers and moderators do not necessarily reflect the official policies of the Department of Health and Human Services, nor does it mention the dimension of trade names, commercial practices, or organizations imply endorsement by the U.S. government. At this time, it is my pleasure to introduce our speaker for this webinar, Dr. David Sprecher. Dr. Sprecher serves as a movement disorders director for Banner Sun City Research Institute and co-director of the Phoenix Tourette Association of America Center of Excellence. He is a neurologist specialized in clinical care and research for movement disorders, including tics and Tourette's. Before moving to Banner Health in 2015, Dr. Sprecher served at the University of Utah as Movement Disorders Division Chief and co-director of their Tourette Association of America Center of Excellence program. He completed his osteopathic medical degree at Lake Erie College of Osteopathic Medicine, medicine internship, and neurology residency at the University of Utah, and fellowship in movement disorders and experimental therapeutics at the University of Rochester. Inspired by personal experiences as an individual with Tourette syndrome, he has dedicated his career to improving treatment options and quality of life for movement disorder patients. And without further ado, please begin your presentation.
Thank you so much. I just want to thank Brenda and the TAA for giving me this opportunity to connect with some new colleagues, reconnect with some of you who I may have already know, and just to kind of give you my own personal perspective about how to be a rock star for your Tic and Tourette patients. Now, as you just heard, I do have one important conflict of interest to disclose that undoubtedly will influence this presentation. These are my other disclosures, but I do have personal experience as someone who kind of had to become a neurologist to kind of figure out that I had Tourette syndrome. So one of the most important reasons for becoming a movement disorder specialist is to make sure that other people can get earlier, more accurate diagnosis, and also be able to find the best possible treatment for their movement disorder. I also want to point out, if I accidentally drop an F-bomb or other profanities, that is not my Tourette's. I don't have coprolalia. So one of the other really important things I want you to come away from this presentation with is just a little bit more comfort about how to decide when something is a tic, an organic tic disorder, as opposed to other types of hyperkinetic movement disorders, and just the differential diagnosis of what the underlying cause is. I also want you to really have some comfort with the common comorbidities, those psychiatric comorbidities, and how to incorporate all of those into that comprehensive evaluation and management plan for your Tic and Tourette patients in order to truly be a rock star for them. Now, tics are a little bit different from most movement disorders in that while they are hyperkinetic, so there's extra movements or sounds that are perceived as unwanted, either involuntary or semi-involuntary, they often resemble typical voluntary movements, and they may sometimes actually be really easy to camouflage. But one important differentiating feature is that they generally are not present 24/7. They're not continuous. They also can vary a lot in their intensity, whether it's the kind of how dramatic the movement is, doing that movement over and over, or that sound. The two key features I think really define tics are that they are stereotyped and they lack rhythmicity. These are movements or sounds where if you watch them long enough, you're always going to see the same repertoire in a given day. While new tics may evolve over time, if you're watching that person on a given day, you still should see the same repertoire over and over again. They also lack rhythmicity. And we'll talk about in a little bit some of the other hyperkinetic disorders that are rhythmic or semi-rhythmic that may co-occur with tics, but that's another important differentiating feature. Now, two items where some of my colleagues like to teach that this is always present, we want to give some qualifiers here. Tics are usually suppressible to some degree, and they are usually characterized by a premonitory sensation or urge. But we'll show you some data to explain that that's usually true, but not 100% of the time. Now, I really want to thank Kevin Black for granting a Creative Commons license to use this video that he put together. This video was developed in order to explain to the lay public what tics are and to show them examples so that they can then answer surveys that can help evaluate prevalence of tic disorders in the general population. So take it away, Kevin.
Tics are brief movements that people don't want to do. Most people never have tics. However, tics are not at all rare, and many people have them at some point in their life. The most common tics affect the head and shoulders, leg.
Wait, can we just go back a little bit? No sound is coming out. You're on mute.
All right, I apologize. My mistake there. There we go.
Snorting.
What about whistling?
And other noises. Lots of people sniff from hay fever or if they have a cold. People who sniff because of a tic will sniff repeatedly even if their nose is clean and their eyes aren't itchy or they don't even have a cold.
Good. That means you're not sick.
Vocal tics are called complex if they involve saying words or pieces of words.
Biscuit. Or biscuit. Biscuit. I've had Tourette syndrome. Biscuits. Biscuits. Since I was a child. Biscuit. But my teeth.
You tell tics apart from other unwanted movements. Tics occur repeatedly, usually many, many times a day. Often tics will occur many times a minute. Some other abnormal movements keep happening on schedule, like the beats of a clock, but tics are different. Even though they may happen over and over, their timing isn't steady and predictable. Tics can change over time. If you know someone with tics, they may have different tics now than they did a few years ago. Sometimes a new tic replaces an old tic. Some tics can be dramatic and noticeable. But many tics are not very noticeable, like tightening your abdominal muscles or quiet, repetitive humming sounds.
Okay, so note to self, never mute yourself when you're playing video with audio. It will mute the audio. So talking about the other hyperkinetic movement disorders, I've listed for you here the other hyperkinetic disorders that can sometimes overlap with or resemble tics. For example, tics can have a myoclonic character to them. They can have some jerking. So in the organic form of myoclonus, that is separate from a tic, there are very sudden shock-like, very rapid involuntary movements. So there can be muscle jerking or sudden loss of muscle tone. But these are not seen with a repertoire of a wide variety of movements and sounds along with. In dystonia, this is also an involuntary movement disorder where there are repetitive muscular contractions, often with a twisting posture. For example, cervical dystonia. But with dystonia, about half of them also have this sensory trait. For example, cervical dystonia, touching the face a certain way helps people straighten out. Now, tics can have a dystonic quality where people have to hold a twisting posture as part of the tic to relieve that urge. But again, it's the company that it keeps and the fact that this is intermittent and often has that suppressibility or premonitory urge. Now, chorea often gets confused with tics because while it is a continuous movement, there are some movements where they may still recur over the course of that movement going and flowing from one body part to the next. For example, chorea in the face, there may be some flowing in the face and then a click sound as the chorea occurs. And so while some aspects seem to repeat, chorea is a continuous movement disorder. It's there pretty much all the time, though it may be exacerbated under stress and so appear to wax and wane in severity. But chorea may be confused with tics. Stereotypies are the main hyperkinetic disorder that often co-occur with tics. Patients with autistic spectrum disorder that are more prone to both often will have these self-stimulating behaviors like rocking or humming. And these are motor or phonic or vocal stereotypies, but they're fairly rhythmic or semi-rhythmic. So it's not only the same movement or sound over and over again, but it has a semi-rhythmic character to it. Tremor, by definition, is rhythmic, but it's really involuntary. And we'll talk a little bit more about functional movement disorders, in particular, functional tic-like disorders. But in general, we like to say that the functional movement disorders are really a wild card because they're pretty much plus or minus with any of these characteristics. They're one of the only other conditions other than epileptic myoclonus and tics that may occur out of a background of normal sleep, for example. But we'll cover that in a whole separate slide because this is another important topic when covering tics and Tourette's. So I'm an adult neurologist, but I also work quite frequently with children and adolescents who are being considered for or managed for a potential primary tic disorder. And I can tell you one of the main instances where tics often may be anticipated is when they already occur in someone who has one of the other two symptoms that are considered to be part of the Tourette triad because they're so commonly comorbid. And those are ADHD or OCD. In fact, because these so often run in families as a triad, if there's already a strong family history of OCD or ADHD, we want to watch those children more carefully also for development of tic disorders, primary tic disorders. Because tics are more common in special education populations, particularly those with Down syndrome or PDD, autistic spectrum disorder, we want to watch more carefully for tics in those populations. But one of the most common scenarios is that someone as a child has an unexplained problem with repetitive vocalizations, in particular throat clearing or coughing sounds or sniffing that lead to an extensive workup with ear, nose, throat or allergists, even workup for asthma. But then it's soon realized that there are other tics besides just those vocalizations. So when you see unexplained vocalizations that might prompt an extensive medical workup, you want to look also for other repetitive movements or sounds, in particular, because tics tend to start in the face and head, look for those repetitive squinting behaviors or other repetitive facial movements. Some individuals will have unexplained pain, but then when you actually watch carefully, they have repetitive tics that are quite painful, like head jerking or clenching the limbs, for example. Another important topic when we're trying to discuss management of primary tic disorders, so tics and Tourette's, is some of those important clinical pearls about evaluation for secondary tic disorders. Now, rarely a brain lesion due to a demyelinating disorder or a stroke can lead to a new onset tic disorder, but these are very rare, and we generally don't see this extensive evolution over time with new ones appearing over time, old ones going away, waxing and waning features when there's just a primary lesion causing the tic disorder. Now, medications, we'll talk about some of the qualifiers when thinking about the role of stimulants. But it's true, stimulant medications, particularly drugs of abuse, when somebody is high on cocaine or amphetamine, they can have hyperkinetic movement disorders, tics or chorea. Back in the 80s, they even called it crack dancing when somebody was high on crack and having chorea and tics at the same time. One of the medications that's been reported in several individual cases to be associated with onset of tics, may go away when the medication is discontinued, has been lamotrigine. But I want to emphasize for some patients, it's an important treatment for their mental health condition or for epilepsy, and it's not a reason not to use lamotrigine in someone who already has a tic disorder. Very rarely, tardive tics have also been reported. Now, besides chromosomal disorder like Downs, tics can also be seen not just as a manifestation of, but even a presenting symptom of trinucleotide repeat disorders. I personally have had one patient whose presenting neurological symptom along with epilepsy was just a tic disorder for a condition known as DRPLA, which is closely related because it's also a trinucleotide repeat disorder to Huntington disease. Tics have been reported as a presenting feature of Huntington disease, but it's extremely rare. Chorea still remains the defining neurological symptom of Huntington's. Now, I want to just briefly touch on infectious and post-infectious. Tics have been reported in people who have active infection. We've also seen it in reports, in my own experience, as a delayed post-infectious syndrome following infectious encephalitis. I've seen it, for example, following herpes simplex encephalitis. Now, with the post-streptococcal form, this generally, the most common presentation is Sydenham chorea, which includes tics, chorea, and then neuropsychiatric features like obsessive compulsive disorder, other behavioral symptoms. Now, streptococcal cultures would be ideal to identify strep infection when trying to diagnose Sydenham chorea. But sometimes we need to go by titers if the patient has already had resolution of their manifest symptoms. ASO is the titer that peaks first. But in my experience, if someone's infection was more than a month or so ago, we'll see a later peak in the anti-DNase B. So anti-DNase B is something that will peak later than ASO and can still be useful to decide if a person who has both chorea and tics has Sydenham chorea. But PANDAS still remains an area of active research and ongoing definition and redefinition. So the initial definition of PANDAS by Sweeto and colleagues in 1998 was a very acute onset of tics and potentially other neurological symptoms like chorea, and neuropsychiatric symptoms, in particular obsessive compulsive disorder, with an explosive onset in close association with group A streptococcal infection. Later, the term PANS was also developed to describe the syndrome where there are neuropsychiatric symptoms that also have an acute onset, but there aren't clear neurological symptoms, and is acute onset in association with streptococcal infection. Now, there remain some unanswered questions, but also some new ways of thinking about this. First of all, there seems to be some interesting overlap with some antibodies that are seen in both Sydenham chorea and in pandas. In particular, those individuals with pandas who also have chorea have the same antibodies to dopamine receptors in the brain as people with Sydenham chorea. For those with pandas who don't have chorea, those still have antibodies seen in the other two groups to calcium calmodulin kinase 2. So there seems to be some neuroinflammation in all three groups. Now, one of the challenges is, what do we do with these patients who did not have a very clear diagnosis of streptococcal infection when their tics first started, but still seem to have acute exacerbations of tics every time they have an illness that appears to be infectious in nature? So potentially viral syndrome, we don't know unless we do cultures. Well, in 2011, a multi-center prospective study was published by Leckman and colleagues that answered this question. What they found is there are a subset of individuals with primary tic disorders, otherwise looks like tics and Tourette's, that have exacerbations every time they're sick. But each time they got a throat culture or got other titers, the exacerbations did not appear to be correlated with a strep infection. Rather, it was correlated with any infection. So we want to bear in mind there's still unanswered questions here about how to approach those patients. But the standard of care is not to give prophylactic antibiotics just because someone happens to have strep infection at one of these later times. Prophylactic antibiotics are important for people who have clear-cut Sydenham chorea, however. That is the standard because that shows patients are going to be prone to, again, developing worsened neurological symptoms with recurrent infection, as well as other systemic problems, such as cardiac valvulopathy. The other really hot topic, and it's a very important topic when following children, adolescents, and young adults, is this really significant increase in the presentation of functional or psychogenic tic-like disorders in the COVID era and the post-COVID era subsequently. These are individuals who have very rapid onset of tic-like movements and sounds, which they usually perceive as completely involuntary and have low or no suppressibility. They also generally are very much more varied than what you see in an organic tic patient. So I want you to think back to some of these patients that you've recently seen where you've questioned, is this an organic tic disorder? And I challenge you to think about whether they have the exact same movements or sounds over and over again. Most of them do not. And they can also appear to have fairly continuous and very severe and dramatic symptoms. In fact, these individuals have been shown to be much more prone to coprolalia or copropraxia-like phenomenon and to injurious phenomena such as hitting self or others. They often resemble behaviors that are witnessed online, hence the term TikTok tics. And they often seem to really focus on parroting these words or phrases from TV shows or movies. So when you start to see stuff like this, particularly if it's in a young adult with no prior history of tics, you really want to think more about a functional tic-like disorder. Now, the treatment can still overlap and usually has to be multidisciplinary and involve a mental health professional to prescribe medications for psychiatric comorbidities that contribute, and then a whole team of therapists, behavioral therapists to address comorbidities, and then behavioral therapists potentially to provide therapy for the tic-like symptoms that uses the same tenets of the CBIT that's used for organic tics. But now for something completely different. This is what Dr. Tourette would look like if he had the syndrome that bears his name. If there were audio to this presentation, you might hear some very inappropriate words or phrases, some sniffing perhaps, but you can see there's the same movements over and over again. Now, by definition, Tourette's syndrome or Tourette's disorder starts in childhood. In the DSM, we define that by age 18. In some other research settings, we define it up to age 21. But there need to be multiple motor and at least one vocal or phonic tic present at some time over the course of the condition. And there needs to be a total of at least 1 year of symptoms before we move from that provisional tic disorder or transient tic disorder diagnosis to calling it a chronic tic disorder, such as Tourette's. It used to be in the earlier DSM versions that there had to be a consecutive 1 year period, but now it just needs to be 1 year total. And this should not be clearly due to a medical condition or medication alone. Many people just have motor tics or just have phonic tics. So it is kind of ticks and fleas, so to speak. We're still defining a spectrum of the same syndrome. So if I happen to see your patient and I redefine them and say, well, it's actually not a chronic motor tic, it's really Tourette's, or if I change it from Tourette's to chronic motor, we're still talking about a spectrum of the same disorder. And that's a primary tic disorder. And one of the key features is that premonitory sensory phenomena. This is an urge that often builds up if the tic is suppressed. It often correlates with tic severity and worsened quality of life. And it really overlaps with something called just right experiences, where people need to perform these evening out behaviors. If they do the tic on one side, then they have to do it on the other. If they touch a door with the right hand, then they have to touch it with the left hand to feel just right. They may even have to say a word at just the right volume and repeat it until it sounds right. There's also overlap with obsessive compulsive symptoms where they do the movement in a certain situation, but one differentiating feature is that if it's an obsessive compulsive symptom, so it's a compulsion, they're doing it to relieve anxiety. So for example, I used to have this kind of compulsion every time I heard the word cancer, I'd have to spit, or at least now I can just put some spittle under my tongue and feel like I spat. Otherwise, I'd feel like I was going to grow a tumor inside me. So I'm doing it to relieve anxiety. So in that case, we call it a compulsion. But many tics are specific to a situation and can resemble a compulsion, like these evening out behaviors or doing a certain number of repetitions. And that's where we may use the term compulsive tic. Another way to look at it is what types of premonitory urges are reported. And I say the top three are either that urge to move, that feeling like they just had to do it, or just a buildup of tension or restlessness. Those are kind of the top three ways that people describe it. And very often younger kids just say, well, I just feel like I have to do it, or I feel bad if I don't. But here's where another qualifier is, it's not 100% of people, particularly in the under 10 population, that report suppressibility or premonitory urge. The most recent worldwide study on this topic, published in 2016, found that in the under 10 group, less than half reported premonitory urge, and about 66% reported suppressibility, versus nearly 80% having premonitory urge after age 12, and well over 90% having suppressibility after age 12. But it's not 100%. So just because people can't acknowledge urge and or suppressibility doesn't mean it can't be a tic. One of the largest worldwide surveys to date found that Tourette's syndrome is seen in about 1% of boys and about 0.25% of girls. So it's still at least 4 times more common in boys than in girls. Chronic tic disorders are seen in about 1.6% of the pediatric population, with transient tics, another 3% of the population. So when you add up all the numbers, that's nearly 5% of the pediatric population having tics at least some point in their lives. So this is a very common symptom that may be present as the nervous system is maturing, but in many cases may go away or improve. And we'll talk about time course in a moment. Tics also are more common in children in special education. One of the largest studies to date was by my mentor, Roger Curlin, back in 2001 in the upstate New York population. So about 23.4% of tics of children in special education versus 18.5% of kids in the regular school age population were felt to have at least some potential tic by a trained observer. Bear in mind, his reported percentages are higher than that worldwide survey. And so this is one of the highest reported tic prevalences to date, but certainly a big difference or significant difference was reported in that special education population. So one of the most important things to consider when we're seeing a person with a tic disorder is to also evaluate for psychiatric comorbidities, in particular OCD and ADHD. Comorbidities are the rule, not the exception. One of the largest multi-center studies to date was from the TAA Genetic Consortium, which found that 86% of Tourette patients had one and 57% had two or more comorbidities, including 66% having OCD, 54% attention deficit with or without hyperactivity disorder. Another important thing to discuss is even though the label for all stimulants says that they can cause tics, there have been two subsequent studies, one by the Tourette Syndrome Study Group in 2002 and one by Ken Gatto and colleagues in 2007, which both showed that compared to placebo, not only does methylphenidate not appear more likely than placebo to be associated with tics, in that large multi-center study, tics were less of a problem in people on methylphenidate or guanfacine, alone or in combination, than in the placebo group. Patients on amphetamine salts may potentially still see emergence or exacerbation of tics that can improve when the medication is discontinued. So general recommendation is to consider starting with either methylphenidate or atomoxetine before an amphetamine salt, but all three options are still on the table. Another important question that we ask when we're getting to know our patients is about family history. We often see that there may be a family member with OCD or ADHD on one or both sides of the family, but then the child has tics or even the full triad, OCD, ADHD, and tics. There was a really nice study from the Baylor group. Dr. Jankovic, Joe Jankovic was the senior author on this study, showing that in their Tourette syndrome population, 84% had at least one parent with a history of one or more of these triad symptoms. 25% had a history on part of both parents. Tics were more common in the fathers, and obsessive compulsive symptoms more common in the mothers. And in fact, there are some families where the female members of the family are less likely to be diagnosed with tics and more likely to be diagnosed with an anxiety or obsessive compulsive disorder. So if we consider tics and OCD/anxiety to be a phenotype of the same spectrum, some families even have shown what looks like autosomal dominant pattern of inheritance if you consider those to be manifestations of the same syndrome. However, to date, very few families have been found to have just one gene that explains all the symptoms. There's so far to date just one family described by the Yale group with a mutation in the histidine decarboxylase gene that did seem to explain it in all family members. So in my family, when I was much younger, this is my daughter back then, she's about 20 now. We ourselves encountered this problem, and this may happen to some of you as clinicians. What do you do when your spouse raises concern about repetitive huffing noises like my daughter was having? Well, first step is start to look for signs of other motor tics that might tell us, hey, this could just be a vocal tic. Let's not worry too much. Let's just observe it and see if it improves over time. So I want you to just get a sense of what the tic might be, and you can kind of get a sense of me asking about it and her not being bothered by it in the least. You have an itchy nose, sweetie?
No. What kind of feel like? Just a second. It's just feel like. I wish it was like a little upper. Pigeon nose, that's why. Anyways, yeah. I wish what they made out from, but.
So in the end, this turned out to be a both motor and phonic tics. I can even remember she's 6 here, but when she was 10, I remember sitting quietly with her and her, making some vocal and motor tics, huffing or twitching, never being aware that she had it. And, she's one of those individuals who just has not noted any tics as an adolescent or as a teen or young adult. So it does happen. So we often hear from people, though, that they were told by their pediatrician or their pediatric neurologist not to worry about it, that this is just a tic and you will outgrow it. Call me if it doesn't. And I just want to kind of step back and talk about that a little more. Where does this data come from? And is that really the best approach? The two groups who probably kind of started this odyssey of really understanding the temporal course of Tourette's were the Cleveland Clinic team and the Yale group, which found that about half of children who were followed to young adult years were nearly tic-free by that time point. About 25% stayed the same, and another 25%, 25% improved, but then another 25% stayed the same or got worse. However, the Rush group, and this is back before the turn of the century, also did a study of these individuals who felt tic-free. And what they found that though 90% of these young adults feel while these individuals felt tic-free, 90% of them still had tics that could be appreciated by a trained movement disorder expert. So we had video recorded of these individuals who felt tic-free, and the movement disorder experts still observed tics. Just like that video of my daughter, you could see her kind of scrunching her nose over and over again and appreciate there's still a tic, she's just not aware of it. I tried to research this when I was starting out as a junior faculty member in Utah, and we tried to follow up some of those individuals from the Tourette Genetic Consortium study who had been seen as children. Now they were young adults, and a lot of them were lost to follow-up, but the 10 I was able to get a hold of and bring in for MRI studies to try to do functional MRI and understand this tic improvement. It was hard to do because of the 10 people I found, only 2 felt improve, and none of them really were tic-free. And another important problem is, so far, those prospective studies only followed male patients. And David Lichter at SUNY Buffalo, up in upstate New York, really found that in his adult population, there was 1 woman for every 2 men in the adult Tourette clinic. So even though 4.5 boys are seen for every 1 girl with Tourette's, the proportion of females seems to be much higher in the adult population, which raises concern that the outcome for women may be different than men. And we want to be careful about just brushing this off and telling parents, particularly the girls, that they're just going to outgrow it. In particular, we also want to follow them up within at least a year and watch for that evolution of the tics, as well as development of or evolution of comorbidities. And that's because while tics typically start between age 5 and 6, and there's a range there, tics usually peak between age 10 and 13, often right before puberty. And so if we're seeing a younger child, we still want to follow them up again, advise parents there's going to be this peak so that they're not, panicking when they see it, but also to follow up and decide if there's tic-related disability to address once that happens. And again, that improvement often occurs in late teens or young adult years, but people often still describe exacerbation of the tics during stressful times in their life or following a medical illness. There have been even case reports back in the 20th century of individuals with profound improvement of tics in their young adult years that then reappear in their later adult years. So for most people, Tourette syndrome is a lifelong disorder, but still improves as they get older. And this is in large part because, not just because the tics improve, but they learn how to manage them and how to live with them. There's a lot of research now that has improved our understanding, not just about the complex genetic predisposition that can be inherited for Tourette's, it's rarely monogenic, but also about some of the neurochemical changes in pathophysiology. We see neuroimaging evidence of a hyperactive dopamine releasing system. We see evidence not just from neuroimaging, but also from neuropathology studies of reduced inhibitory neuronal density and GABA levels in the striatum. With functional MRI, we see less mature patterns of functional connectivity in teens and young adults with persistent tic symptoms, as well as reduced caudate volumes. And as I mentioned, there is one mutation in histidine decarboxylase suggesting a potential role for histidine in at least one Tourette family. So when we see someone with tics and comorbidities, we want to ask about hyperactivity, and in particular, many of my colleagues, myself included, will use the Vanderbilt assessment, which is a nice questionnaire that's available open access. The Vanderbilt questionnaire that comes with an answer key that helps you decide if they have attention or hyperactivity predominant symptoms. And it's something that both the parent and the teacher can fill out in advance of the appointment with you. Obsessive compulsive disorder, the Yale-Brown Obsessive Compulsive Disorder Scale has some really nice examples of obsessions and compulsions to ask about that can guide your history taking. And there's both a child and adult version for that. And all the usual screens for depression and anxiety are so important. Now, when somebody has both tics and ADHD, and we really need to address the ADHD, alpha-2 agonists can be of modest benefit for ADHD, but when it's really problematic, we may want to start with either methylphenidate or atomoxetine, but it's still okay to use amphetamine salts if they're indicated, if these other agents are not effective. Most people do tolerate without profound exacerbation of tics. With OCD anxiety spectrum, it's important to emphasize that SSRIs and other antidepressants have a role for OCD anxiety symptoms, and since people tend to tic more when they're anxious, it has an indirect benefit for tics, but it's not a direct tic suppressing medication. And cognitive behavioral therapy may be important to start with first if OCD anxiety is more problematic than tics. We want to do CBT before we consider the CBIT. So overall, we want to ask what is the primary source of disability and develop a hierarchy of what we want to address first. I often will start the interview if it is an older child adolescent, teen, even young adult that comes with their parents, I always want to clarify, what are your goals? And I'm asking the patient, are you here because you're concerned about this? How does it bother you? How are you impacted? Why does it upset you? And a lot of kids just say, I just want it to stop. I just hate that I have to do this. And that's where you get the sense it's a kind of a door opener to then talking about treatment. Also really important to clarify, are they being singled out at school or at home for something they can't help? Are they being bullied? And this is something that will be delved into a lot more when they work with a CBIT therapist. We often will write letters to get them a 504 educational plan or individualized educational plan. I've even written letters to get people reasonable accommodations in the workplace, because tics are protected under the Individuals with Disabilities Act, and the teachers are required to provide appropriate accommodations in the school place. In the workplace, you just want to make sure that you're asking for reasonable accommodations, things that really can be done. If somebody has tics that upset a customer, I had someone who's a massage therapist, and the customer complains when they're ticking while they're massaging them, there might not be a reasonable accommodation for that scenario, but in most cases we can come up with some reasonable accommodations for school or in the workplace. But very important that you start by developing a list of the tics and a hierarchy of the ones that are problematic, and not only how they bother the person, but whether they potentially could cause injury or actually do cause pain. So we talked briefly earlier about CBIT. Comprehensive behavioral intervention for tics goes over stress management strategies, talks about factors that may tend to bring out tics or reinforce tics. In particular, in the pediatric population, that's particularly important because we don't want to inadvertently reward tics in the home or in the school. So we have to be very careful in terms of having a balance between reasonable accommodations versus rewarding people for ticking. And that's really the role of the therapist, to develop an individualized plan for that. The main tenet of CBIT is habit reversal therapy. And I personally sometimes will do a modified version of this where I'll try to coach people on developing a competing response that they will do every time they identify that urge to tic, that they do in place of the tic for at least a minute or until the urge goes away, whichever is longer. And that's something that it really takes time to practice, recognizing the urge and then practicing the exercise to a point where it starts to come naturally. And eventually that particular tic often will improve, but then a new tic may emerge over time. And there is data from at least one very large study, one of the first studies on CBIT, showing similar efficacy compared to placebo intervention to what we've seen with some of the medication trials. That said, there are some qualifiers there. If someone has very severe tics, it can be really hard to start CBIT. And so sometimes we do have to have this compromise where people keep an open mind about medication if tics are too severe for them to actually undergo CBIT. But CBIT really is considered first line in many, many cases. And if you don't have access in your region of the country, there are a couple of online resources available for independent use or guided with the parent. Both tichelper.com and also Tic Trainer are options to consider. Now, the Tourette Association of America has an advisory board that still has a nice document on management of tics, and they have this kind of algorithm that they put in there about potential pharmacological management of tics. One thing I want to point out is that while haloperidol and pimozide were the first two FDA-approved medications for tics, they are not necessarily the typical antipsychotics that you're going to see recommended by most movement disorder specialists. We generally don't like pimozide because it requires EKG monitoring. And I'm the adult neurologist who is starting to see people who were started on pimozide a long time ago, and now I'm having to figure out how to switch them to something else because it's not something you want someone to take into their later adult years that can then cause QT prolongation. So this is kind of my approach. And I still want to defer to the Tourette Advisory Board to constantly update and improve their recommendations for management of tics. But I think all of us would agree that education and CBIT are first line. Education is always important. CBIT is often first line. And in people with relatively mild tics, particularly if they have comorbid ADHD, alpha-2 agonists can be very helpful for both. And I even have some adult patients who may have had ADHD when they were younger, and they don't realize how much it was impacting them until they start that alpha-2 agonist for the tics, and then the ADHD is also improved. Similarly, while there's only one small placebo-controlled trial from the Baylor group on topiramate versus placebo showing a benefit, this is a medication that's important to consider if someone has problematic comorbid migraine or comorbid epilepsy, because it can serve as a dual therapy. Now, when tics are more severe, particularly if there are tics that are causing pain, that are really interfering in school and the workplace, or potentially self-injurious, that's where we do want to make sure people understand antipsychotics do have an important role as tic suppressing therapy. Aripiprazole was approved in the early 2010s specifically for management of tics. And some of the newer direct-to-patient mail-order pharmacies have very reasonable pricing for aripiprazole. So it's not covered by insurance. It still can be very affordable no matter what. Aripiprazole and risperidone are the ones that I consider preferred because they still have a lot of dopamine receptor activity. Even though aripiprazole is a partial dopamine agonist, it overall turns down activity at the dopamine receptor. So the more dopamine receptor blocking activity an agent has, the more tic suppressing activity it has. The other important thing to emphasize is that tardive dyskinesia is extremely rare in people who take an antipsychotic for tic disorders. It can be seen in 7% of those who take an atypical for behavioral health reasons, and even much higher prevalence in those taking typical antipsychotics, for example, for schizophrenia. But in over 200 patients reported from the Baylor group, not a single one had tardive dyskinesia. And I can count on the fingers of one hand the number of adults I've seen develop tardive dyskinesia taking an antipsychotic for Tourette's, in my experience over 15 years of being a Tourette expert. Botulinum toxin now is recognized in the American Academy of Neurology practice parameters as appropriate and indicated for patients with problematic focal tics. So if someone has a very severe neck tic and they could really hurt themselves, we may want to start with botulinum toxin much earlier, for example, for that tic. Now, the dopamine depleters, while some groups, including the Baylor group, like to start earlier with these and may consider them first line, they still don't have placebo-controlled evidence for their use. And so while we can all tell you that we have patients where this is the only thing that's worked for them, they still take extra work to get approved from insurance because they are very expensive. So tetrabenazine and then the newer formulations of tetrabenazine that are potentially better tolerated, deutetrabenazine and valbenazine, do have a role in those refractory patients, but can be sometimes hard to get approved by insurance unless you've shown that they've either failed or have a contraindication to these other classes. Deep brain stimulation has a worldwide registry now with over 300 cases that have been implanted worldwide for refractory tics. But we want to make sure that these are severe cases where the risks outweigh the benefits and that we continue to monitor them as part of this worldwide registry to better understand what are the best targets and what to expect with implanting patients with DBS for tics and Tourette's that are truly refractory to all other measures. So I hope you come away with this understanding that in most cases, you don't need a very extensive workup with extensive neuroimaging or ASO titers in every patient who appears to have a complex chronic tic disorder without any neurological symptoms that would point to a secondary tic disorder. And I hope you come away appreciating the value of that comprehensive assessment also for the comorbidities, and to develop a comprehensive plan that addresses both the tics and the comorbidities. While many people do outgrow their symptoms and improve as they get older, overall, while Tourette's is a lifelong disorder for most people with a comprehensive plan and a rockstar clinician can live well despite, and sometimes even grow stronger because of, tics and Tourette syndrome. So I'm just going to close on the lecture now, and we're just going to jump ahead and look for some Q&A. First of all, in terms of copies of the slides, I'm going to just point out that this is a recorded session, so the recording will be made available through the Tourette Association of America. So more to follow on that. In terms of migraine, migraine is a very common neurological condition. In some studies, as many as 30% of people, particularly if you ask neurologists who are very attuned to the symptoms, probably 30% of us have migraine at some point in our lives. In people who also have migraine, who have Tourette's, but also have migraine, those tics, particularly the head tics, can really, really worsen the migraines and worsen tension headaches as well. So if a patient has a problem with headaches, but also has tics, then topiramate is a medication. While it's considered off-label, it's a very affordable medication. That's a medication I may consider as a dual therapy. And Brenda pointed out, if you have any additional questions that haven't been answered today, you can email support@tourette.org. Another thing that I wanted to point out is we had a really important comment that many individuals are becoming occupational therapists certified in CBIT. So ways to learn who is CBIT certified in your area, you can go to the TAA website and look up Find a Provider, and then you can find providers who are certified as CBIT specialists. And in particular, our training sessions that are being offered throughout the year are geared to occupational therapists. So if you or someone you know are an occupational therapist interested in learning about CBIT, I really encourage you to attend one of the upcoming CBIT training sessions. Marissa Barth put in a comment there that she needs to finalize her training and get her first patient to treat in order to get CBIT certified. So please reach out to her if she's in your area in order to help her complete her training. So we had a lot of helpful comments in the beginning. I think that covers all of our audience questions. And again, please do reach out to support@tourette.org, whether you're watching this live or as a subsequent recorded version, if you have any further questions about managing your tic and Tourette patients. Thank you, and it's really been a pleasure to speak to you today.
Okay. Everyone, I also just wanted to let you know, well, first, thank you so much. That was an excellent presentation. And I just want to let everybody know that we're going to send out a survey on the presentation, and we would greatly appreciate it if you would be able to complete and provide your feedback. And we're going to, after I send out that survey, I'm going to send out a follow-up email with a link to view the recording. Additionally, the webinar is going to be posted on our YouTube channel for those who are unable to participate today. We encourage you to reach out to us about this webinar or any ideas or suggestions that you maybe have. On behalf of the Tourette Association of America, thank you again for joining us and taking the time to view our presentation. Have a great day, everybody.